Hi, everyone who's joining me here at this little poster site. I am going to be talking about this poster, which describes work that was funded by the Drug Evaluation Alliance of Nova Scotia and was completed using methodology originally developed by the Canadian Network for Observational Drug Effect Studies, CNODS. We were interested in this question about antimicrobial dispensations for urinary tract infections in women residing in long-term care because bacteria are commonly found in the urine of adults residing in long-term care facilities. The estimates say up to 50% of older adults residing in long-term care have bacteria in their urine. Now, that doesn't mean that 50% of adults in long-term care have an active urinary tract infection, but because when you're testing urine and you find bacteria, there can be a propensity to want to treat. And there are actually really good guidelines that say specific situations whereby you should treat a urinary tract infection. And it's not every single time you find bacteria there. The objectives of this particular study were to describe antimicrobial use for uncomplicated urinary tract infections and compare outcomes of patients who are dispensed a fluoroquinolone to the outcomes of those dispensed other antimicrobials. It was indeed a retrospective cohort study where we selected women 65 years of age and older who resided in a long-term care facility in Nova Scotia and were dispensed an antimicrobial agent, which we found to be for a urinary tract infection based on diagnostic codes identified adjacent to that antimicrobial dispensation. The time period was quite long, from January of 2005 to March of 2020, and the outcomes of interest were looking for essentially failure of the original antimicrobial prescribed, such as a subsequent antibiotic dispensed, follow-up visit with a physician emergency department after that urinary tract infection event, or hospitalization due to a urinary tract infection event. So quite staggeringly, we identified 15,276 uncomplicated urinary tract infection events in women over the period of study. That was in 7,078 women, which means that there were many women who had more than one urinary tract infection over that period of study. Quite exciting, I guess, from our perspective, is if you look at figure 1, you can see that the number of uncomplicated urinary tract infection events in each year declines significantly over the study period. That yellow line shows quite clearly that the number of urinary tract infections identified was decreasing year on year on year. If we look at the second figure, we can see that the dispensation of different antibiotics changed quite a bit over the period of study. In the beginning, we see that sulfamethoxyl trimethoprim was most frequently dispensed and cephalexin was the least frequently dispensed. But as time goes on, we see that sulfamethoxazole use and nitrofurantoin use decreases, and we see that amoxicillin and cephalexin use increases. This was a little bit unexpected because beta-lactams like cephalexin and amoxicillin are not typically prescribed for uncomplicated urinary tract infections. However, it may be a signal that the urinary tract infections that were being treated weren't sort of characteristically uncomplicated, or it may be a trigger that there is concerns about using agents like sulfamethoxazole and nitrofurantoin that require dose adjustment for chronic kidney insufficiency. So it's possible that there is just a preference for agents that have less real dosing requirements. We found that fluoroquinolones, when used, resulted in fewer women receiving a subsequent antimicrobial or a follow-up visit for a urinary tract infection event. However, there was no increase in hospitalizations associated or decrease in hospitalizations associated with fluoroquinolone use. Our findings overall suggest that antimicrobial dispensations to women living in long-term care is declining, and that fluoroquinolones do show some benefit because they were associated with a decrease in subsequent antimicrobial dispensation, and they were associated with a decreased need for follow-up care. However, their side effect profile and the risk for drug-drug interactions is quite high, and it still likely outweighs the potential benefits and suggests that we should continue with guideline recommendations to use agents like sulfamethoxazole, trimethoprim, and nitrofurantoin as our first-line agents. Thank you very much, and please leave questions for me in the spot.